Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the 19th session out of a series of 30. So today we're dealing with ventilatory muscle function, part 3. This is the Great Adventure, Pediatric Pulmonary Physiology. And as you can see, we're moving along. We want to approach this with the enthusiasm of a child in a candy shop. So we talked last time, or a couple times ago, about the respiratory balance, and that is that ventilatory muscle power and central drive need to be adequate to overcome the respiratory load in order for the balance to tip in this direction and have adequate ventilation. We also found that ventilatory muscles can fatigue, and that could potentially tip the balance in this direction into respiratory failure. So today we're going to talk about clinical issues in diaphragm fatigue, developmental changes in the chest wall, and development of the human diaphragm. Clinical issues in diaphragm fatigue. As we mentioned last time, there are 7 contributors to diaphragm fatigue: hypoxia, hypercapnia and acidosis, malnutrition, hyperinflation, infancy, increased respiratory loads, and disuse. Look at this preterm infant. Why can't this baby breathe? This baby has ventilatory muscle dysfunction in addition to lung disease. This child is potentially hypoxic and hypercapnic, certainly malnourished. We can't nourish babies in the latter trimester of pregnancy as well as the mom can in the uterus. BPD is often associated with hyperinflation. There's clearly an increased respiratory load. Infancy we'll talk about today, and oftentimes these babies have been on a ventilator for a while before a pulmonary consult is obtained, so they also have changes of disuse. So the clinical consequences of ventilatory muscle weakness. Inspiratory muscle weakness means there's an inability to actively inspire fully and a potential for atelectasis. We go around breathing not just a half-liter tidal volume all the time, but we take size periodically to expand areas of lung that might otherwise collapse. So this fights atelectasis. Expiratory muscle weakness means that you have an inability to cough effectively, and therefore there are retained pulmonary secretions, which predisposes to pneumonia. So these combine to predispose children with neuromuscular disease to pneumonia. And if a child is having severe or frequent pneumonias, you might think that his or her ventilatory muscle strength is much weaker than you thought. Severe ventilatory muscle weakness, of course, will result in hypoventilation and respiratory failure, and this often requires chronic ventilatory support. And that's basically the respiratory balance. So airway clearance facilitates movement of thick secretions into large airways where they can be coughed out. I often refer to this to patients and families as the ketchup bottle model of the lung. If you want to get ketchup out of a bottle, you turn it upside down and pound on it. The aim is that we do airway clearance for 30 minutes twice a day just to keep disease stable. It's often required more frequently during acute infections. Several methods are equivalent: percussion and postural drainage, the high-frequency chest compression vest, and aerobic flutter or a cappella. So we literally used to turn patients somewhat upside down and pound on them as shown here. We now have other modalities of airway clearance, particularly the high-frequency chest compression vest, which is the most common or most popular method of airway clearance in the United States. There are also these so-called internal methods that basically when one exhales through them, there's kind of a pulsing sort of air front that, if you will, helps to shake loose secretions. Cough assist device is a different issue. So airway clearance is used to move secretions from small airways into large airways. If somebody has a neuromuscular weakness and cannot cough, then a cough assist device is helpful. This essentially is an artificial cough. It can be used via tracheostomy or mask. It first delivers a positive pressure breath in adolescents or adults of 35 centimeters of water, followed by a negative pressure breath of minus 40 centimeters of water, and usually repeat 3 to 5 cycles. This essentially simulates an artificial cough, a deep breath, and then a forced exhalation out. And again, it's useful in people with a weak cough And we already talked about the fact that part of your physical examination for someone with neuromuscular disease is to ask them to voluntarily cough. Patients with ventilatory muscle weakness usually need help clearing infected pulmonary secretions to prevent pneumonia. Traditional chest physiotherapy moves secretion from middle and small airways into large airways. The cough assist device removes secretions from large airways, and primarily it's important to note that patients with a weak cough require both of these modalities, not one or the other, both. So again, in clinical law, always ask patients with ventilatory muscle weakness to cough during your physical examination. David Gozal was a pulmonary fellow here at Children's Hospital from 1990 to 1993. And he asked, is there a physiological predictor of children who can be weaned from chronic ventilation? Turns out that the max PDI, transdiaphragmatic pressure, and the max airway opening pressure, or maximum inspiratory pressure, or PI max, are poor predictors of who can be weaned from ventilatory support. Because infants and young children may not give maximum effort, true PDI max and airway opening max may not be achieved. Can prediction be improved by maximizing respiratory drive, i.e., delivering an increased fraction of carbon dioxide? And can it be improved by measuring the ability to sustain maximal PDI or maximal airway opening? Dr. Ghazal did a study where he measured PDI max and essentially MIP breathing, fraction of inspired oxygen 100%, fraction of inspired oxygen 100%, and a fraction of inspired CO2 of 5%, and a fraction of inspired oxygen 93%, and a fraction of inspired CO2 of 7%. 24 children on chronic ventilatory support were consulted for failure to wean. 19, or 79, successfully weaned within 3.2 plus or minus 1.9 weeks, and 5, 21%, remained ventilator dependent for 8.3 plus or minus 5.3 months. When he looked at those who could be weaned versus not, this was the maximal PDI, and as you can see, it was, not surprisingly, higher in the patients who could be weaned, either breathing oxygen, 5% CO2, or 7% CO2. The spontaneous breathing, PDI over PDI max, so this is the ratio. And remember, we talked about normal individuals have a PDI max of around 100, and probably during quiet breathing use a PDI of about 5. So their spontaneous breathing PDI to PDI max would be 0.05. So you can see here that those patients who were able to be weaned had a lower, that is, they used a lower fraction of their max PDI when they were breathing, generally speaking. And the results are fairly similar, whether they're breathing oxygen, 5% CO2, or 7% CO2. Mean opening airway pressure, again, higher in the patients who could be weaned versus those who could not. And so we're going to talk for a moment here about sensitivity, which is the probability of a positive test if a disease is present, specificity, the probability of a negative test if the disease is absent, positive predictive value, which is the probability of a disease if the test is positive, and negative predictive value, the probability there's no disease if the test is negative. Dr. Ghazal looked at those patients that had a PDI max greater than 70 centimeters of water to predict weaning. And the sensitivity was good, specificity not so good, breathing oxygen, and so on. It was a little bit better, breathing 5% CO2. It looked overall like 5% CO2 was the better predictor. Sustaining greater than 60% airway opening pressure, max, greater than 60% of that for 5 breaths to predict weaning. Again, 5% seemed to be the best. Both 70%, greater than 70% airway opening pressure and sustaining greater than 60% airway opening pressure for 5 breaths to predict weaning. You can see again, all were better, but breathing 5% CO2 had the best sensitivity, specificity, positive and negative predictive values. PDI max greater than 60% to predict weaning. Again, 5% seemed to be the best. Sustaining greater than 60% PDI max for 5 breaths to predict weaning. Again, 5% CO2 best across the board. And both a PDI max greater than 60 centimeters and sustaining greater than 60% of PDI max for 5 breaths. You can see that really breathing CO2 was perfect. It had 100% sensitivity, specificity, positive predictive value, and negative predictive value. The remainder were not too bad and were improved, but 5% seems to be the magic. So measures of ventilatory muscle strength alone, PDI max and P airway opening max, are only fair predictors. Measures of ventilatory muscle endurance alone, that is, ability to sustain greater than 60% PDI max or airway opening pressure, are only fair predictors. When measures of both ventilatory muscle strength and endurance are used, one achieves the best prediction of ability to wean from chronic ventilatory support. So again, we're dealing with the fact that the ventilatory muscle power must be able to overcome the respiratory load. So let's look at an episode of acute respiratory failure taking into account ventilatory muscle function. So it's plotted on the y-axis is work of breathing and time on the x-axis. So one develops a bad pneumonia, or let's say something that's going to become ARDS. Work of breathing increases. Right? Now we have on this axis what we're going to call the fatigue threshold. This is the level that somebody below which someone can sustain spontaneously more or less indefinitely. But greater than that requires assisted ventilation. So here this patient gradually gets worse, crosses this fatigue threshold, and suddenly crashes. That is, now he requires ventilatory support. The disease worsens and gradually improves, and eventually, once the work of breathing falls below the fatigue threshold, then the patient can be weaned by perhaps a number of parameters. Chronic respiratory failure is a little bit different. Same thing. We have a disease that starts, let's say, in a child with some degree of ventilatory muscle weakness, but work of breathing now exceeds what that child can do. Ventilatory support is required, but the work of breathing never comes back down to the level the patient can sustain, so this patient cannot be weaned and has, by definition, chronic respiratory failure. In order to wean from chronic ventilatory support, one of two things or a combination has to happen. Either the work of breathing needs to decrease back down to this fatigue threshold, and or the fatigue threshold has to increase, possibly by ventilatory muscle training, as we've talked about before. But basically, one of these two things, or both, have to change in order to be able to wean a child from chronic respiratory failure. All right, now, let's talk about developmental changes in the chest wall. So first, of course, you all know, children are not just small adults. We can look at the thoracic cross-sectional area of an infant, which is more or less circular, and a child or adult. The surface area here is much greater. Now, this, of course, is the diaphragm at the bottom of the thoracic space, so that means there's much more muscle to work with in order of being able to ventilate. This just plots the anterior overlateral thoracic diameter. So in the baby that had a circular sort of configuration, this number is closer to 1, and with age, as you can see, this tends to fall, meaning that the thoracic cage is increasing in lateral diameter and increasing overall in surface. It's actually kind of shown here. You can see a fetus, 7-month-old term, etc., to the thoracic configuration. This is kind of a horizontal slice across the thorax for different age groups. In terms of thoracic configuration, in an infant, the rib cage is horizontal, whereas in a child or adult, it's at an angle. Again, this just shows for age the rib slope index. So rib slope index of 1 is horizontal, decreased values indicate a downward slope. And you can see that with age, this becomes a much more downward slope, not horizontal. So compliance. Remember, compliance equals change in volume over change in pressure, and we can measure compliance of the lungs, for example, the chest wall, and the total respiratory system. The pressure walk here, if we want to measure compliance of the lung, the pressure we use is alveolar minus pleural. If we want to measure compliance of the chest wall, then it's barometric minus pleural pressure. So we can, in fact, measure thoracic compliance. Total respiratory system compliance, of course, is just mouth pressure minus barometric. For more than one compliance in series, that is one after the other, the reciprocal of compliances are additive. So, for example, when you take a breath, your lungs, you go through lung compliance and chest wall compliance sequentially, if you will. And so these reciprocals of these add to be the reciprocal of total respiratory system compliance. And so here we have pressure volume curves of the chest wall in blue, of the lungs in black, and the total respiratory system in dotted lines here. And you can see that in an adult, the chest wall compliance is relatively stiff and it springs outward so that the FRC is actually quite a bit up here at a reasonably high percentage of total lung capacity. In the newborn infant, you can see that the chest wall compliance is much more flaccid, if you will, or less stiff, and consequently, there's not as much outward recoil, and the FRC is in fact much lower than in the adult. So chest wall compliance, high compliance means less stiff lungs, falls with gestational age over the first, from prematurity to a couple of weeks post-term, over about this 3-month period. This shows chest wall compliance again in individuals from full-term birth out to 4 years of age. And again, you can see that it falls. During growth, the main static change in the rib cage is increased outward recoil. The infant rib cage is pliable and distorts easily with more negative intrapleural pressure or more negative intercostal muscle tone, i.e. REM sleep. Lung disease requiring more negative intrapleural pressure sucks in the compliant rib cage, and this increases work of breathing. So here, in an adult, you can see that the diaphragm is configured in this sort of way so that its contraction is going to bring abdominal contents down. In the infant, the configuration of the diaphragm is flat across the thorax. So unfortunately, part of the action of the diaphragm is going to be to bring the anterior and posterior portions of the rib cage together rather than actual diaphragm function causing air movement. The horizontal rib cage in infants, diaphragm contraction moves the lower rib cage inward, that's rib cage distortion. The diaphragm descends less, increasing abdominal pressure less, expanding the rib cage less, and therefore there is a decreased efficiency of diaphragmatic contraction. The area of apposition we talked about is much less in the infant than it is in the adult. Remember, this is the portion of the diaphragm parallel to the abdominal wall that causes the piston action. So there's less in the infant than there is in the adult. Laplace's law also comes into play here. If you have a nice rounded diaphragm here, okay, you've got a relatively small radius of curvature. So remember, the pressure generated in this case by the diaphragm is 2 times the tension of muscle over the radius. So a small radius is going to give you more pressure generated by the diaphragm. If you have a relatively flattened diaphragm here, the radius of curvature is huge, and therefore the pressure that the diaphragm can generate is much less even for the same amount of muscle tension. In the upright position, abdominal contents act as a weight suspended from the diaphragm. This applies a uniform subatmospheric pressure to the diaphragm, increasing thoracic volume. In the supine position, abdominal contents apply a non-uniform positive pressure to the diaphragm, and this decreases lung volume by about 15% in adults. And this just shows this here. The weight of abdominal contents here tend to pull uniformly so that the diaphragm, again using that fulcrum action described initially by Duchenne, will spread and raise the base of the rib cage. In the supine position, abdominal contents are moving the diaphragm up, and diaphragm contraction is not nearly as effective. In the upright position, the vector of the diaphragm will elevate the rib cage. In the supine position, the vector of the diaphragm tends to pull the rib cage inward. In supine, there is a decrease in rib cage excursion, and most rib cage excursion may be due to intercostal activity in the supine position. Diaphragm thickness does increase with postmenstrual age, so in this case from prematures up to full term, you can see that there is a steady increase in the thickness of the diaphragm. So the chest wall of infants versus adults, there's horizontal rib cage in infants, there's incomplete rib ossification, there's a flattened diaphragm, there's a lower thoracic cross-sectional area, higher chest wall compliance, thoraco-abdominal asynchrony, and the respiratory muscles in infants are at a mechanical disadvantage to develop force because of the differences in the chest wall. Infants have increased worker breathing, therefore. How well can they handle it? So let's look at development of the human diaphragm. Chip Scott was a neonatal perinatal fellow at Children's Hospital, Los Angeles, 1979 to 81. And he did a study looking at development of the human diaphragm. So he measured transdiaphragmatic pressure, and we've talked about that before. An esophageal balloon measures interpleural pressure, gastric balloon measures abdominal pressure, PDI is abdominal minus pleural. Again, the gastric balloon and then an intraesophageal balloon. And this is a picture of one of the balloons he actually used in his study. So initially, when we did this study, we were actually interested in the question about whether abdominal wall defects like gastroschisis or omphalocele or congenital diaphragmatic hernias had an effect on maximal transdiaphragmatic pressure. And we measured a number of babies over full term, that is 9 months post-conceptual age, out to about 5 or 6 months. Okay, and you can see actually that there was a developmental pattern here. There actually didn't seem to be much difference between the different pathologic conditions, and we got much more excited about an overall developmental pattern. So when we plotted these, what in fact we saw was that all of them had an increase in abdominal strength from about 5 weeks post-conception to about 13 or 14 weeks post-conception. And that's really illustrated by that part here. In addition, by serendipity, we had the opportunity to study 3 patients who were initially on a ventilator and then subsequently got weaned from ventilatory support. And you can see that there was a marked difference. The measures when they were off the ventilator were higher than the measures when they were on, suggesting that in fact transdiaphragmatic pressure or diaphragm function does in fact or can in fact influence one's ability to be on or off ventilatory support. One can also measure combined institory muscle strength, which is just mouth pressure, and this actually has been done by some other investigators. So this group of investigators looked at PI max from birth up through about 3.5 years of age. Now note that this is the only portion of their measurement that would coincide with Dr. Scott's measurement of diaphragm strength. Nevertheless, these investigators concluded that there was not a developmental pattern of increasing ventilatory muscle strength through infancy. Similarly, this group of investigators basically measured, again, PI max, which is crying in this case, so the methodology we talked about before, at day 1 and day 6 of life, and again, you don't see any change. So we have 2 groups saying there does not appear to be increased ventilatory muscle function during infancy, and of course, our study with Chip Scott saying that there is. So maybe we should turn to Bertrand Russell, famous philosopher, who said, "It is profoundly instructive to learn that one has been wrong about something. It combats ignorance and it opens the mind to new ideas." Well, the question is, who's right and who's wrong? Dr. Scott showed that diaphragm strength decreased in infants. The other 2 investigators showed that combined institory muscle strength may not be decreased in infants. None of the investigators could reconcile these results. First of all, the latter studies were done after Chip Scott studied the diaphragm, so we did not know about them. And the other two authors did note our study, but didn't have a way to reconcile the differences. I'm going to suggest to you that we are right, and I'm going to show you some physiology in a few minutes that might explain why we believe that diaphragm strength is decreased in infants and increases with development. So again, the Hospital for Sick Children during the Golden Era, 1979 to 77. Um, as mentioned previously, C. David Inuzzo was a um, biology professor at York University in Toronto um, and a muscle physiologist. A. Charles Brown was my mentor, a pulmonary physiologist at the Hospital for Sick Children, University of Toronto. Okay, recall that that all human skeletal muscle is uh, formed of fiber types, and all muscle has certain percentages of these types. Slow twitch fibers, which are high oxidative, fast fatigue, are fatigue resistant, would be expected to be seen in muscles requiring endurance. Fast twitch fibers, which use ATP slowly and or inefficiently and have decreased oxidative enzyme capacity, are shown here. So these are fast fatigue. As mentioned, the same amount of ATP is used for each of these twitches, but for a slow activity like breathing, you would like to have more area under the curve, more tension time area to sustain breathing than these fast twitch fibers, which might be effective in eye blinking, for example. So in human skeletal muscle fiber types, there are basically two. There are subtypes, but type 1 is high oxidative, slow twitch, and therefore fatigue resistant. Type 2 is low oxidative, fast twitch, and therefore fast fatiguing. So this is a photomicrograph from a human diaphragm of a 10-year-old, and this, I will just tell you, is the adult pattern. So the darkly stained fibers are stained for oxidative enzymes in muscle cells. And you can see that approximately half, a little bit more than half, of the fibers are these darkly stained, high oxidative, fatigue-resistant fibers. This is the human diaphragm from a full-term newborn infant, full term. So again, these dark fibers are the fatigue-resistant, high oxidative, slow twitch fibers, and I think you can see there's a decreased proportion of these compared to the adult. This is a 28-week preterm infant, and you can see that there are actually very few of these fibers indeed. All right, so that in this particular case, there are probably about 10% of all the fibers are the fatigue-resistant fibers. And you could imagine that if this infant is faced with some sort of increased respiratory load, respiratory distress syndrome, for example, that this infant would not be able to perform much work against an increased respiratory load. These are the data from the entire subject. This is percent of type 1 fatigue-resistant fibers in the human diaphragm. And this is plotted on a log scale of time at 20 weeks gestation, full term, 1 year, 10 years of age, and adult. You can see that the adult pattern achieved by about a year of age is about 50 to 60% type 1 fibers. Full term infants have about a 30%, 25 to 30% um, type 1 fatigue resistant fibers. Preterm infants have only about 10% or less. So again, it's not surprising that they cannot perform much in the way of work of breathing. So the infant diaphragm has decreased fatigue resistant muscle fibers. There's decreased ability to generate energy. It uses energy less efficiently. So this predicts that this would predispose the infant's diaphragm to fatigue. One can look at fatigue of the diaphragm objectively using muscle EMG changes. So when fatiguing loads are applied to muscle, there's almost an immediate decrease in high frequency and increase in low frequency EMG spectrum, so-called power frequency spectrum analysis. The high-low ratio of the EMG spectrum decreases with muscle fatigue. The diaphragm EMG spectrum can be measured by surface electrodes. So here's what happens. If we plot energy at different frequencies in the electrical signal, all right, With fatigue, all right, the low frequency increases and the high frequency decreases. All right, so fatigue is the dotted lines. In the low frequency, it increases. In the high frequency, it decreases. So if you take a ratio of high to low, the high-low frequency ratio decreases with fatigue. Recall Harris Rusas and Peter Macklem's classic study where he showed that the diaphragm can fatigue if you have to breathe greater than 40% of your max PDI on every breath. Remember that this is what he showed, that here somebody's breathing along adequately, maintaining the target transdiaphragmatic pressure, and here is fatigue. And recall again, this was at 40%, this ratio. So Dietze Gross, working with Harris Rusas and Peter Macklem, did the same study, but in this case, she added electrodes. In this case, she used esophageal electrodes, but subsequently, people have shown you can do this with skin electrodes as well. So these were esophageal electrodes looking at the diaphragmatic EMG. So same experiment here. We're going to require subjects to generate increasing proportions of their max PDI on every breath, but now we're going to look at the EMG. If one was breathing at 25% of the max PDI, we know that fatigue will not occur, and you can see the high-low ratio did not fall. 50% is just above the threshold, and you can see that with time that did fall, and 75% is well above the threshold, so that you can see that the high-low frequency ratio fell quickly. So the question now is, do infants fatigue? So Nestor Miller, who was at Toronto following me, looked at high-low ratios of the diaphragm EMG in newborn infants on ventilators. So here a child was on a ventilator, and you can see the child was taken off the ventilator, was weaned, and the high-low ratio fell, and eventually the child had to be put back on the ventilator. I will tell you, the physicians taking care of the kids did not have access to these data, which actually had to be generated later. So this just shows, based on clinical decision making, the child was in respiratory failure here from diaphragm fatigue and had to go back on the ventilator. Conversely, here's an example of a child who successfully weaned from mechanical assisted ventilation. So here you can see that the high-low ratio never changed, and this child was able to remain off the ventilator, as shown here, at least for 5 hours. Here's an example, and we'll talk about this in a little bit, of a child being on CPAP, newborn infant again, taken off CPAP, and again, diaphragm fatigue occurs, and then is put back on CPAP. So CPAP stabilizes the rib cage and to some extent reduces work of breathing. So infants can develop diaphragm fatigue with increased respiratory loads. Diaphragm fatigue does not occur with successful weaning from ventilatory support, but it can cause respiratory failure in infants, and it does occur when one is not able to successfully wean from the ventilator. So what have we learned today? In order to achieve adequate ventilation, ventilatory muscle power must be adequate to overcome the respiratory load. The diaphragm is the major muscle of breathing, and the intercostal muscles function to optimize diaphragm function. Diaphragm strength, or PDI, is measured as abdominal pressure minus pleural pressure. Combined inspiratory pressure is maximal inspiratory pressure, or PI max, and that's a measure of combined inspiratory muscle function. Expiratory muscles are most useful in coughing, and these are primarily the abdominal muscles. Ventilatory muscles can fatigue. If one must generate greater than 40% of max PDI in each breath, diaphragm fatigue will occur, causing respiratory failure. Ventilatory muscle endurance is resistance to fatigue. Ventilatory muscles can be trained to increase strength and or endurance, and ventilatory muscle training causes cellular change. Contributors to diaphragmatic fatigue include hypoxia, hypercapnia and acidosis, malnutrition, hyperinflation, infancy, increased respiratory loads, and disuse. Immaturity of the infant's chest wall puts the diaphragm at a mechanical disadvantage. Diaphragm strength and endurance are decreased in infants compared to older children and adults, and this predisposes the infant diaphragm to fatigue, which can cause respiratory failure. Again, the respiratory balance here. Now we focus now on the fact that Ventilatory muscle power must be adequate to overcome the respiratory load. Starting next time, we're going to shift to thinking about central drive. Central drive must also be adequate. Perhaps all of this ventilatory muscle physiology is best summarized by Peter Macklin, who was at the Meekins Christie laboratory at McGill University, a prominent respiratory physiologist. And he said, a pulmonologist who is interested only in the airways and not in the ventilatory muscles is like a cardiologist who is interested only in the blood vessels and not in the heart. So next time we will explore control of breathing 1. Our thanks to our producer director, Katie Lewinter, and thank you so much for joining me for the great adventure, pediatric pulmonary physiology.